Okay, thank you. And today I will talk to you about, can you hear that? I can't hear is it coming through? Okay. I'm sorry, I'm just getting over a cold, so hopefully I'll make it through. Talk about our study that we call the Indiana Genomics Implementation Opportunity for the Underserved. And I think there's probably three main reasons that I was asked to come and talk about this one. Number one, the intervention we're using we think is highly relevant for underserved populations. Number two, it addresses some of the primary endpoints that we think are highly relevant for the sustainability of genomic medicine. And number three, we've developed some of the approaches to overcome some of the barriers to recruiting patients from remote locations across the entire state of Indiana. So you can see at the end whether you agree or not, I guess. So like any good study, you have to come up with an acronym for it. And after a couple beers and a weekend, we came up with INGENIOUS as our name, which you can see what it stands for. And this is funded by a NHGRI network called the Ignite Network, which stands for Implementing Genomics into Practice. Network that was set up about 6 years ago. And this, we've just completed enrollment of this study, and I'll talk a little bit about some of the characteristics of the population. So the idea of this was to test the effect of pharmacogenetic genotyping on the number of adverse events and consequently the total healthcare costs of those patients that are genotyped versus ones that just receive drug therapy as a standard of control, or standard of care, sorry. So that's what the two primary endpoints were. And this is conducted in two healthcare systems in Indiana, Academies healthcare system, which is our safety net hospital system in downtown Indianapolis, as well as the IU Health healthcare system, which is a statewide system that includes about 16 hospitals across the state. We've completed enrollment. There's about 1,300 patients in the genotype guided arm. It was a 2-to-1 randomization. So the standard of care therapy was a little over 3,000 patients. And I'll show in a second the drugs that we've focused on. It's pharmacogenetics. And so the question then becomes, why do I think this is relevant for underserved populations? Well, drug therapies, predicting response to drugs oftentimes requires some sort of intense monitoring of the drug response, which in many cases that's fine if you have easily access to healthcare and you're in a state where you can routinely go in and get monitored. However, many of the underserved populations, number one, if they're in medically underserved areas, they're a much further distance away from the clinic they need to go to get whatever that monitoring is. Many people don't have paid vacation, so if they go in to get this, whatever this test was my doctor told me to get, it means I'm going to take days off work, and it's going to mean less pay in addition to the transportation costs, which can be significant for people who are living day to day. And if they spend the $3 or $6 to take the bus to get this test, that means one less box of cereal on the table for their kids, or some of these sort of real world problems that they may have to sacrifice if they don't, or if they spend the money on this. So these sort of things oftentimes mean underserved patients have less of this regular monitoring, which can be really helpful for therapies if you can get it done. And I've used oftentimes as an example, there was a study that compared genetic testing for warfarin, which is also Coumadin, or it's also rat poison, but it's a blood thinner that's used quite frequently in patients. And if genotyping was compared to patients who came in and got regular monitoring, 3 times a week of their INR, which tells whether they got the right dose or not, and there wasn't in that the primary endpoint of that there wasn't a big effect, but that's in patients who went in 3 times a week and got there, in the beginning to get the dose right. Well, if you're one of these patients that doesn't actually do that, it may be a whole different scenario. So if we can get the right dose to the person at the right time in that initial visit, because they're not going to come back for that monitoring, then maybe they can. It may be much more effective in an underserved population than in the general population. So just a couple statistics, and then I'll show you the drugs that we addressed. So as I mentioned, there was about 1,300 in the genotyped arm, about 3,000 in the control arm. These were recruited from the two healthcare systems I mentioned. Eskenazi is one hospital with a variety of outpatient sites. That was done by phone recruitment. So when they got a prescription for one of the 27 medications, which I'll show you, they then were asked to come back to the hospital and met in person to collect a blood sample, which was then genotyped. And the IU health system, which we enrolled people from 14 of the 16 hospitals across the state. That was not feasible to drive clear across the state for every one of those enrollees or patients we enrolled. And so we did the phone recruitment, and then we established an online consent, which we could have them fill out the consent online, which then came back, and we then uploaded a request form to the IU Health medical care system, so they could go to any hospital they wanted, whichever was closest to them, and get their blood drawn, which then got couriered downtown through the regular courier system. And so there was a little bit of difference between those, partly because of the location. And I'll show you where the patients were recruited from. The patients were identified based on them getting a prescription from one of 27 different medications. We identified these electronically through a daily report that came. We did a variety of other screenings. As you can see in the gray bar, oops, can I go back? Yeah, we received, well, you can see there's 18,000 alerts for potential patients that could be recruited, and then randomized them. And of those 14,000, we actually weren't able to reach for a variety of different reasons. We're still evaluating what those were to figure out what it was, but we did end up with the close to 5,000 that we recruited. So I sort of went through this a little bit. Basically, they're identified through the Cerner and Epic reports that we got every week. Then the genotyped arm was phoned. This was a pragmatic study, so the control arms were not contacted at all to try and minimize the risk of them saying, oh, really, I should be genotyped. Maybe I better go actually get this done, and contaminating that arm with the genotyping. So they were not actually contacted. I mentioned a little bit about the difference between the systems. When we got the genotyping information back and the medication data, we had an adjudication committee that looked to see, based on their genotype, should we make a recommendation to their provider to alter their drug therapies? And if they did, then that was returned directly back to the provider through either an email or, in some cases, a phone call. And then the endpoints at the end of the study, which we're now starting to collect, is the adverse events and the economic data extracted from the medical records. And I should say, in this sort of a study, so in 2014, there was a study that counted up the number of cost-utility analysis studies for personalized medicine in personalized medicine studies, and there was a grand total of, I think it was 39 studies total. In drug therapy ones, it was like 1,300 and some. But that's a very small number when you consider the fact that the last numbers I saw, there's about 75,000 genetic tests on the market, and there's a grand total of 39 of them that have any sort of cost-utility analysis. So as Dr. Tunis earlier was talking about, as we're going to our, what I like to call our custodians of our healthcare dollars, some people refer to them as payers or insurance companies or something. If we think about them as really custodians of our dollars, one of the things they really want to know is, how does the genetic medicine impact the actual bottom line, because that's part of the business that we need. They're not an unlimited bank account, an ATM that we can just keep pulling stuff out of. So this is just briefly, just to look at it. These are the top most common drugs that are part of our study. As far as the enrollment, the number of subjects, you can see in that column is the number of subjects in with that drug that were enrolled. Brian, you'll be happy to see there's a lot of psychotropic drugs on here. I think 7 out of the top 17 of them are psychotropic drugs. And then there's a variety of other ones in there. This is the after the final recruitment's done, the number of people in the control and genotyped arm. You can see 2,700 were white, black or African Americans, about 1,300, and then a few of the other ones down there were a few of those. One of the things that we can do, because we have over 90% of the patients are racial and ethnically identified, we could generate the report that I just showed, but also we have geocoded information in the vast majority, over 80% of the population, so we can actually track back where they live to the different areas of the state to figure out how many are in medically underserved areas and populations. In order to do that, we use this map, which looks they're a little bit different color up there, I think. But the ones that are colored either in the solid or the crosshatched ones are areas that are either federally designated medically underserved areas or populations are the solid colors, or are the one color, or the ones with the crosshatched ones are areas that are the governor's exception, so they're also considered medically underserved areas and populations. So having this, and where the little red H's are is where there's the IU Health hospitals, so we can combine this with our enrollment data, and you can see here the areas there where there are red counties are places where we've recruited patients from that are in, the red counties are counties that we've recruited patients from and are medically underserved areas or populations. The gray areas are other places where we've recruited patients from that are not actually medically underserved areas or populations. You can see, we've just looked at the genotyped arm only. 37% of them are from those areas, and there's some that we don't know for sure because not 100% of them are geocoded in the database. But there's some of both, so this will allow us to generate some hypotheses going forward too, as far as what differences between the groups. And then just quickly, a couple graphs that show some information. The control and intervention arms by the insurance groups, Medicaid, Medicare, low income, private pay, self-pay, and others. The difference between the healthcare systems, the Academies is a little higher in the Medicaid and low-income payers. We calculated the number of, or the success rate of enrollment and the number of times we needed to actually call people to per successful enrollment. This is the success or enrollment success rate. It's higher in the IU Health, which is a little lower in the underserved patients. I think this will be valuable going forward in our future studies so we can better estimate the amount of calls and things we'll need to make. This is the number of calls needed per enrollee, so it was 5 times more in Academies in the Safety Net Hospital than in IU Health. And then just at the end, when we enrolled them, we asked them, what do you think? Is it a good idea to get genetic testing to find out whether you'll respond to a certain medication? And then you can see on the bottom what the potential answers were. And there was basically no difference. So the vast majority of them, over 80%, said yes. Well, of course, these were people that enrolled in the study too. But right. So, but then we looked at, was there a difference between underserved areas, populations, ethnicities, and a whole variety of things. And basically, there was no difference between any of those groups in the answers to those questions. Do you plan to share the pharmacogenetics results? And the vast majority said yes. There was no difference between any of those demographics again. And who do you plan to share them with? And you can see family members are the vast majority of them. And then just, I think, quickly, the lessons learned. Remote recruitment can be used to successfully enroll patients and collect samples from underserved areas and populations. We don't have the infrastructure to do this set up, so we can do it in a lot of future studies. Direct-to-patient recruitment can reach patients in underserved areas. These are, we actually, after they got the script, we didn't need to go through the provider. We could directly call the patients based on a policy that our healthcare institution set up that allowed us to do that. Our tools exist to identify these underrepresented areas, and more resources may be needed for some of the safety net hospitals. Then we did some questions at the end in a focus group that said, do you want your information back? And they said yes. Do you want your healthcare providers to have it? It's yes. Do you want all your information back? Yes. They were way more concerned about the information they have on Facebook and that the information, then having their genetic data in their medical record system. And that's it, just a bunch of people. There was obviously a ton of people involved in this. That's sort of the general idea. All right, and I'll be happy to answer it.